Welcome everyone to Multi-Modality. I think some of you guys have heard this talk last year, but this is going to be an introduction to peripheral vasculature. Unfortunately, this is also a field that has its own complete specialty, vascular medicine and vascular surgery, and people also specialize in every single vascular bed, so any vascular bed organ system you can think of. People have written books and built entire careers out of that. Unfortunately, I have 1 hour to try to introduce you to all of this. So just some disclosures. And for those of you who aren't aware, there is a certification exam, the Registered Physician in Vascular Interpretation. This is administered by the Alliance for Physician Certification and Advancement. They're responsible for quite a number of imaging boards now, everything practically except for echo boards. And this has now become a requirement for the vascular surgery residents, so they're now required to certify an RPVI. I believe they still have a non-traditional pathway, and so it's an option if you guys do have some exposure to the vascular lab here. Okay, so things I'll discuss. I will give an overview of common peripheral vascular disease entities. I'll also go over some imaging, very briefly, imaging criteria and classification of such entities. I'll go over the imaging modalities and techniques we use to try to assess these things. What I won't go over are entities that were previously discussed in the aortic multimodality talks. I'm sure our colleagues have already given a good overview of that. I'm not going to go over a review of acute or chronic medical management and the supporting literature. That's what the entire specialty of vascular medicine and vascular surgery is for. And I'm also not going to go over a review of procedural or surgical management options and surveillance or the supporting literature. Again, that's an entire field in itself. So when we assess the peripheral vasculature, it truly is a multimodality endeavor. So most centers usually have a non-invasive vascular laboratory, and that's usually the first entry point that patients begin encountering vascular imaging. Of course, then we also have the option of MR angiography and CT angiography using contrast or non-contrast techniques. And there's also fluoroscopic angiography as the quote-unquote gold standard with digital subtraction angiography. In terms of vascular beds, we can try to classify them into roughly these large categories. So we consider them along the lines of cerebral arteries, extracranial and intracranial. We look at extremities and classify them in terms of arterial entities and venous entities. And last but not least, we also look at the abdominal pelvis and all the visceral branches and pelvic branches that happen in there. There are appropriate use criteria. These were published back in 2012 and 2013. And just to give you a perspective, it actually took 2 committees, not one, to cover the entire breadth. This gives you an idea of the entire scope of this area. So without further ado, we'll start off with the first vascular bed. Let's talk about cerebral arteries. And no talk about cerebral arteries is complete without talking about supra-aortic branch. So all of us are familiar with the normal variant, the normal anatomy of the 3 aortic arch vessels with the brachiocephalic or innominate on the right, left common carotid, and left subclavian. Of course, you can have the so-called bovine variant, which is actually a shared common trunk of the brachiocephalic and left common carotid. And then you can also have all sorts of different variations, such as vertebral arising straight off the arch, or an aberrant right subclavian artery as a separate branch. In terms of knowing the anatomy, what does matter for the interventionalist is the type of arch, and there's actually 3 different types. This is how the arch vessels relate in terms of relate to the greater and lesser curvature of the arch. And as you can see, there's 3 different configurations based on the orientation of the brachiocephalic and left common carotid to these curvatures. Why does this matter to the interventionalist? This actually gives them a fair idea of how easy it is for them to land wires and catheters to engage the brachiocephalic and thus the right common carotid for interventions. So it is helpful to note these. Moving up into the intracranial vessels, you can actually talk about the internal carotid and the different segments as it goes through its different curves and paths in the skull. There's actually a classification for that. That's displayed here. And then there's, of course, a circle of Willis. This can actually be evaluated through a technique I'll hopefully discuss a bit later called transcranial Doppler. I won't go into that as much right now. Now, in terms of disease entities affecting the cranial vessels, there's the usual suspects. Of course, stroke is the biggest worrisome complication that we look out for, and ischemic stroke caused by large artery atherosclerosis and cardioembolism are the big entities we look out for. There's also hemorrhagic and transischemic attack, but I won't go into those as greater detail. This should be familiar to all of you being involved in the cardiovascular field. We talk about atherosclerosis, and there's actually an entire continuity of atherosclerosis. Shown are the 8 different HA classification types, ranging from type 1 all the way to type 6. Type 1 being the fatty streaks, and type 4 being the so-called vulnerable plaque, including rupture as well, as shown here. And of course, you have type 5 and type 6, which are the more matured plaques and complex plaque entities. Shown here is also the entity of the phenomenon known as Glagow phenomenon, where there's initial positive remodeling with preservation of the lumen size before you get luminal narrowing in the much later stage of the disease. So by the time you see flow-limiting stenoses in patients in the various vascular beds, this is actually a far-gone progression of the atherosclerotic disease. There's a lot more going on, and those of you in the cardiac CT and MRI realm are very well aware of the plaque positive remodeling that has occurred. In terms of evaluating, in terms of indications for carotid duplex, if there's something present on physical exam or there's known flow-limiting stenoses that are already present, this is a reasonable indication to go ahead and perform a vascular ultrasound. Of course, what we may not be aware of is that in patients with multiple risk factors, cardiovascular risk factors, those we consider at higher risk, these are actually reasonable candidates for vascular ultrasound as well. Of course, and also for stroke risk assessment. Of course, if one develops symptoms or full-blown stroke, this is also an indication. And of course, patients who get revascularized either through stenting or CEA, these are also indications as well. The ESC has actually come up with more recent indications as well. And I'm sure Dr. Zogby and company will be happy to note they did recommend, yes, ultrasound is first in this entity here. Before going on to others. But in terms of what we can actually assess with vascular ultrasound, we can actually evaluate quite a bit, beginning with the carotid intima-medial thickness. This is actually something that's been described well back in the 80s by Pignoli et al. They actually did cadaver experiments and also did healthy volunteers and showed they could see the double parallel line bars corresponding to the intima-medial layers of the arterial wall. And shown here is also the different protocols. This is from the ERIC study, the atherosclerosis risk and community studies, showing the different configurations of the internal external arteries relative to each other and how one has to take that into account. This is a Myers arc that helps us standardize the approach for evaluating this. Now, does this matter prognostically? Yes, it does. It turns out that in a meta-analysis of various large cohorts, they did prove that with increasing quintiles of intermediate thickness, that this does correspond to increased cardiovascular events as well. In terms of plaque, of course, no screening exam looking at the early signs of atherosclerosis is complete without commenting on plaque. And with a screening exam that we have available here with the heart scan, we do comment not only on the IMT thickness, the IMT measurement, but also the plaque presence as well. And this can actually be brought out with a carotid ultrasound contrast, although that's not as used as frequently. Okay. There are some pitfalls. Vascular ultrasound being a predominantly 2D technology can miss eccentric plaque, and so it's important that when you get long axis views that you sweep back and forth, but that you also do transverse sweeps going up and down. That's actually recommended by the different societies. SVU actually redid their overall protocols, and you can find them on their website. They redid it just this past January 2019. It is important to know plaque, as I mentioned, because in the large cohorts I mentioned before, such as the ERIC, cardiovascular health studies in elderly, Rotterdam, and Mesa, and MDCS. This has also been shown to be associated with cardiovascular events. One doesn't need to stop there. Of course, with the availability of CT scans, we can do further characterization of the different plaque characteristics using Hounsfield units, and that's shown in this nice study here back in 2006. And MRI can also of course, use its various magnetic properties to further characterize the different forms of plaque, and also combine it with contrast to show whether or not there's a contrast uptake, further confirming increase in interstitial space or edema. This can actually be taken further. There was actually a company called VP Diagnostics that created software trying to characterize this on MRI. This was the evolution of work that at Dr. Morissette at the Baylor College of Medicine and Dr. Wan and Bill Kerwin at the University of Washington put together, allowing us to see the different features of plaque morphology. You'll notice some step artifact here, but that's because of the way this was acquired. This was acquired in axial slices. Okay. Of course, one can also look at the activity of plaque, and hopefully as soon as we bring our PET scanners online, we can look at so-called hot plaque, which indicates active inflammatory disease as well. And with the 7 Tesla magnet that we have installed on our research institute, we can further characterize it as well. This is, of course, in terms of intervention and looking at flow-limiting lesions, the gold standard is considered angiography, and there are various criteria that have been developed to try to quantify these stenoses in the fluoroscopic suite. NASCET has won out, and this takes the distal vessel diameter as the reference, and allow us to quantify stenosis based on that, although you should be aware other methods exist. Using the NASCET criteria, when one has significant disease and symptoms, it's very clear that these patients should be treated. This is a JAMA article combining the various intervention trials, carotid intervention trials, showing that the number needed to treat once you're over 50% and have symptoms is very low, less than 20. But when it comes to patients who are asymptomatic, and that was shown in the ACAS and VA studies, that this was very controversial, that the number needed to treat is much, much higher. And so that's a discussion that has to take place between the patient and the physicians, of course. Physiologically, this has been shown way back when, almost 4 decades ago, by Spencer et al. They showed that as the lumen diameter decreased, so lumen diameter being wide open on the right of the screen and decreasing to the left, there's an initial increase in peak systolic velocity before it plummets, and the blood flow actually is maintained up until you get about 70–80% or so, and that's when it becomes truly flow limiting as well. Shown here are what happens with the overall cross-sectional area as plaque occurs, and as you get concentric, there's of course a more hyperbolic decrease in cross-sectional area versus more linear decrease with eccentric stenoses as well. Dr. Strandis at the University of Washington came up with the initial criteria of how to grade stenosis using vascular ultrasound, and shown here is his criteria using peak systolic velocity and spectral characteristics. This spectral characteristics fell a little out of favor, but one should be aware, and very much in the echo world, all of you should be aware that spectral broadening is a sign of a turbulence and maybe a suggestion that stenosis, or some kind of stenosis may be developing. This is the more formal criteria that are now used by consensus by the radiology societies. As you can see, spectral characteristics aren't included, but if you talk to the more experienced vascular techs, they still use spectral broadening when they do their preliminary analysis of the study. Okay. One common pitfall that happens in the vascular lab is confusion of internal versus external carotids. Key clues to make sure you're not confusing one versus another. External carotid arteries tend to have more branches. It tends to be a smaller caliber vessel. It also responds to something called temporal tapping. So if you tap on the patient's face, you'll actually elicit Doppler noise, and that's what's being mentioned here as well. So there are there are pitfalls that can happen with vascular ultrasonography with confusing the two, and one has to be careful in evaluating the two vessels. When distal occlusion occurs, and that's being demonstrated here, this can also, shown here is an internal carotid that is occluded with very, very limited flow. This can actually disrupt everything that we expect with peak systolic velocity, et cetera. Here we actually see the peak systolic velocity fall to almost nothing, and of course you'll see very little Doppler flow. And so that needs to be something that alerts you to a more critical occlusion going on. And so you may not see all the turbulence, all the increased peak systolic velocity. So that's something to be aware of. Moving on, when we do carotid assessments, they also assess the vertebrals as well. And one thing we do look at with the vertebral vessels is that there can be what's called vertebral steal phenomenon. And this is a sign that the subclavian artery, which supplies the vertebral arteries in most patients, unless there's an anatomic variant, may be compromised. So the subclavian vessel is occluded or near occluded. The body will make up for flow to the extremity by actually shunting blood or stealing blood through the vertebral artery. So these patients may present with dizziness and also with claudication symptoms, and they're related. So if the patient actually uses their arms, that might provoke a dizziness episode as well. This is important for patients undergoing arterial bypass because, as we all know, the lima vessel is sometimes used, and that's a branch off of the subclavian artery. And so if you see this phenomenon, surgeons need to be alerted so that some kind of intervention or repair can be done to address the subclavian artery as well. Okay. There are also Doppler characteristics that can start cluing you in terms of vertebral insufficiency. And shown here is different Doppler waveforms as there's progressive systolic blunting and eventually reversal in the later stages. I mentioned before that I'd cover transcranial Dopplers for the evaluation of more intracranial vessels, and Dr. Garamy has published this nicely, where we actually do, using a lower frequency ultrasound probe, can penetrate the skull and examine the different parts of the intracranial vessels. This is actually used routinely in vascular interventions involving carotids to look for embolic phenomenon. This can actually also be used to look for intracardiac shunts as well, so they can detect bubbles in the artery as a noise that can be appearing when you inject it through the veins as well. So that's another indication to perform a transcranial Doppler. Okay. There are, of course, unusual suspects. Tortuosity. There is an entity known as Tortuosity syndrome, which is associated with genetic mutation causing dysregulation in the TGF-beta. Dissections also need to be noted. There's, of course, fibromuscular dysplasia and carotid body tumors, paragangliomas as well. This is an example of tortuosity. This is actually a favorite imaging exam question for ultrasound certification exams because this tests whether or not you understand how Doppler principles work. If a dissection is detected, one should also be aware that they should look more proximally and make sure there's not aortic involvement as well. Of course, because the management is going to be very, very different. If it's isolated to just the carotid and vertebral artery, then anticoagulation is indicated in these cases to maintain cerebral perfusion. But if aortic dissections are involved, then of course that could be a medical emergency and the surgeons may need to be involved. We did mention fibromuscular dysplasia yesterday with Concha's very nice professor rounds. This is an entity that affects the intima-medial layers and leading to the so-called string of beads appearance. Usually this is picked up in the renal arteries, but extracranial vessel involvement is also very common. Less commonly, it can involve the visceral and extremities, visceral arteries and extremities, but that should also be noted. Type 1 primarily involves the medial layer, and that's the most common form, but type 2, type 3, and there's even a type 4, depending on what classification scheme you used. A more simplified classification scheme that's being recommended is just commenting on whether or not there's just focal versus multifocal involvement. Okay. I mentioned paragangliomas, and this will show up as a splaying of the carotid bifurcation, and this will be a very highly vascular tumor body. And so when you do a vascular ultrasound, you'll actually see sparkling on the Doppler, indicating and indicating its presence. This is a neuroendocrine tumor, so it could be secreting catecholamines and could be an explanation for hypertension in some patients. Okay, moving on to the next vascular bed, I'm going to briefly talk about arterial diseases. And in terms of extremity arterial anatomy, of course, everyone's familiar with femoral artery, SFA, and the three-vessel runoff into the calf. One should also be aware, of course, the brachial artery bifurcating into the radial ulnar as well. Everyone who goes through cath lab should be aware of this anatomy. But one common confusion that always comes up tends to be when you stop calling it the SFA and start calling it the popliteal, and that has to do with when it penetrates through the adductor canal. So that's a good definition. And another confusion that often frequently arises is which one's the anterior tibial versus peroneal versus the posterior tibial. And a common landmark I tend to look for is the interosseous membrane between the tibia and fibula. Once I see the interosseous membrane, I look for the vessel anterior to that, and that's going to be an anterior tibial. The peroneal is going to run parallel to it, underneath it, and the posterior tibial will be the only other branch running more medial. Okay. When peripheral artery disease does occur, the body doesn't know how to make up for it, so it will collateralize through various branches. And so if you do see a critical stenosis or complete total occlusion, you should begin looking for collateralization either through the thoraco-abdominal walls. Look for superficial arterial branches in the leg or in the calf. Same thing with the upper extremity, and looking at the palmar and plantar arches as well. You can get collateralization there as well. In terms of screening, the very first test that's often done is the ankle brachial index, and this is as very straightforward as it sounds, and we've all encountered this in medical school, I hope. You take the blood pressure in both arms, take the higher of the two, and take the blood pressure in the ankle, and take the ratio of that. Usually that's going to be something between 0.9 and 1.2. If it's less than 0.9 in the leg, that does indicate that you may be dealing with PAD. Between 0.9 and 1.0 is considered equivocal, and anything above 1.2, you should be concerned for calcific disease. One thing you may not be aware of is that there is such thing as exercise ABI. So just because a patient may have a normal ABI, but they may still have claudication symptoms, and so one can refer them for exercise testing, have them walk on a treadmill in a trained center, and see what the ABI is after exercise. I won't go into this in great detail, but this is the ACC-HA PID guidelines using ABI for stratifying patients and deciding on management. If you do establish that PID may be present, the next step is to establish which level, and before taking them to the angio suite. And there is some such thing as segmental blood pressures. And this is as medieval as it sounds. What they do is they strap blood pressure cuffs all along the legs, and then using Doppler waveform, check the blood pressure at the various segments. Or they can do what's called pulse volume recording as well, which is just looking at pulsatility, kind of like a plethysmograph, looking at when blood's restored as the pressure is deflated. And of course, if you notice more than a 20 millimeter drop at a certain level, that's suggestive of disease at that level. And that warrants a further investigation for the vascular surgeon, or peripheral interventionalists. They can then do an angiogram and then finally diagnose where the lesion is, if it's multifocal or not, and then design our intervention as well. Okay, I'm going to skip that. There is such thing as oxygen tension and perfusion pressures as well, and using sensors that can detect the pulse ox in the legs and feet, you can measure how much oxygen content is present in the leg. This is very useful in patients who have limb ischemia or non-healing ulcers, because then it tells you how well they're perfusing down there, and that can also decide management, and if need be in the case of limb ischemia, that's not amenable to intervention, maybe the need for amputation as well. Okay. These are criteria for arterial duplex in the extremities, and as you can see, it borrows some pages from the carotid ultrasound world. They look at spectral broadening as well. They look at peak systolic velocity reductions along the vessels. And they also, in addition, combine it with arterial duplex and can also look at plaque characteristics as well to look for flow-limiting lesions. How do we do it in the CT MRI world? This is also straightforward physiology. We usually give both an we give a bolus of contrast and we chase it down in both the arterial and venous phase. And shown here is an example from of what happens when we inject contrast in the IV. It's going to go through first pass, enter the heart, and then enter the arteries, and that's when we can have a window to try to capture it using CTA or MRI using contrast-enhanced studies. If we wait a bit later, of course, then the veins begin to fill, and then we can get the so-called venous imaging as well. In the CT world, we use iodine, of course, and in the MRI world, we have the option of gadolinium. Both of those, of course, are contraindicated in end-stage renal patients or advanced chronic kidney disease patients for various issues. Iodine is considered nephrotoxic, whereas gadolinium, there's an increased risk of NSF, nephrogenic systemic fibrosis. There is a third option. This is off-label use, as I mentioned I was going to discuss, and that's the use of ferriheme. And these are iron nanoparticles that actually shorten the T1 time and therefore have contrast-enhancing properties. This can be given in patients who cannot get iodine or gadolinium contrast for whatever reason, but we can still do vascular studies in the MRI world, contrast-enhanced studies. Okay. Let's see if this will play. Shown here are our MIPS, and this is just demonstrating arterial phase on the left and venous phase on the right. You can see here only the aorta and the arterial branches are lighting up, whereas here you can actually see the SVC up here, IVC down here, and the portal venous system also lighting up. In terms of its diagnostic performance, CTA and MRI, they're actually very, very good in terms of detecting PAD. As you can see, it's upwards in terms of 95+%, and this is comparable to ABI in detecting PAD. Of course, one feared complication in the cath lab after routine coronary angiography or procedures is pseudoaneurysm. And so shown here is the swirling pattern. Some would dub this the Pepsi-Cola sign, where you have the red and blue on color Dopplers. So this is evidence of a pseudoaneurysm and thus an indication for consideration of intervention. If it's small, less than 1 centimeters, some centers will just simply compress this and let it thrombose that way. Others, if it, of course, if it's larger than 1 centimeters, then it may need a thrombin injection. The vascular surgeons can go in with a needle and do a thrombin injection and precipitate a clot that way. But if it's sizable enough, the vascular surgeons may need to go in and do some kind of repair as well. But this is an entity that should be recognized, especially for those who are in the interventional world. Last but not least, there is an entity known as thoracic outlet syndrome, and this is caused by the scalene muscles in the neck. So sometimes first cervical rib in some patients who have that anatomy. And what this does is it actually causes pinching of the subclavian artery as it exits out from the neck, near the neck region out into the arm. And these patients will initially not have any symptoms, but when you cause a provocative maneuver, here it's called the ASA maneuver, where you raise your arm and have them turn their head the opposite direction. This actually causes pinching of the artery. And this may be grounds for the surgeons to go in and remove a part of the clavicle or rib or muscle to improve symptoms as well. This can also affect the nerves and veins and can cause complications that way as well. There's something known as popliteal entrapment syndrome, where if the patient moves her calf a certain way, this can actually lead to entrapment and stenosis of the popliteal artery. Not very easy to bring out, and trained centers usually have to do these maneuvers to bring this out as well. I'm not going to go into this. And last but not least, on the more research-related front, there is something known as brachial artery reactivity testing, or BART for short. What this does is try to monitor for the response of the brachial artery to vasodilate after a vaso-occlusion with a blood pressure cuff. This lets you gauge an idea of how much nitric oxide reactivity there is, and that's as a measure of vascular health. It's kind of a corollary to carotid IMT in a way, if you will. So in patients who don't react, who don't dilate up their artery, may be a sign of impaired endothelial function. Okay. So moving on from the arteries to the veins. Veins tend to be a bit more straightforward. One thing that I point out to trainees as they come through the lab is that in the more distal limbs, like the forearm or the calf, for every arterial branch you see, there's going to be 2 veins flanking it. So if you see on a vascular ultrasound study or any other imaging modality, you'll always see the artery in the center and the two deep veins flanking on either side. So if you ever get confused about the anatomy, if you see the 3 vessels, that's a way to guide you in terms of what's vein and what's artery. In terms of venous pathology, a common complaint that patients come in and after you work them up and make sure there's no organ issues with the heart, liver, or kidney, or any kind of other obstruction is chronic venous insufficiency. Veins do have valves, and if those valves deteriorate, and that's seen commonly with age, and more commonly in some patients, you will get edema and other findings as well. Of course, we all fear DVTs and venous obstruction. That's another entity that we look out for. And of course, there's arterial venous malformations in some patients who are genetically predisposed. In terms of venous insufficiency, there's an entire classification system here. I won't go into great detail, but this is testable. This sometimes shows up on cardiology boards as well. You should know that based on clinical, etiologic, and anatomic and pathophysiologic mechanisms, there's this entire grading scheme. On DVTs, if you ever review the vascular ultrasound, you'll actually see it as non-compressible vessels with flow loss. There'll be loss of respiratory variation. There will be loss of pulsatility. You can actually do maneuvers to try to bring out more blood flow and create venous variations, but these will all be likely absent in the presence of DVT. On MRI, we can actually do something called the TI-600, which because the thrombus won't pick up contrast, it will tend to appear dark and black, with some exceptions. It turns out when thrombus first manifests, it actually has shorter T1 and longer T2. So in an acute period, you'll actually see it's bright, and then as it evolves over time, the T2 signal gets lost as the platelets and fibrin begin remodeling and squeezing out the water, so to speak, and you also lose the T1 signal. So if you do see bright signals associated with a suspected thrombus, and you see, this will let you know that's maybe not chronic and maybe subacute. Moving on to AV malformations, there are some entities that one should be aware of, and they're very striking if you ever come across them. I haven't come across them myself. There is Klippel-Trenaunay Syndrome, which is malformations of the veins and lymphatic systems. That's to differentiate from Parkes-Weber syndrome, which involves the artery. So this one's actually concerning because it involves the arteries and can lead to AVMs and AV fistulas, and can increase blood flow and does cause a high output state in the patient. This one's less concerning, but it's still something that should be monitored as well. Moving on to the final vascular bed, there's of course the abdomen and pelvis. And of course, there's the renal arteries and the renal veins. Usually the left renal vein crosses over the infrarenal aorta underneath the SMA to get to the IVC. IVC is located to the right of the abdominal aorta, if one ever gets confused, and this will become important for matters I'll mention later. And of course, there's the portal venous system, which we don't routinely evaluate, but we can. One should be aware of visceral artery dimensions. where did the other slide just go to? Okay. One should be aware of visceral artery dimensions because every now and then you'll see ectasia, and on occasion we'll actually come across arterial aneurysms. Splenic artery aneurysms are the most common, followed by hepatic arteries, and then other aneurysms are more rare. The reason why I bring up splenic artery aneurysms and that you should note them is because if you do see them and they're above a certain size, 2 centimeters is the magic number. If they're above 2 centimeters, those are at higher risk for rupture. And when they rupture, it's catastrophic. The patient can hemodynamically collapse and have from a massive bleed and needs immediate medical attention. So usually when you see something over 2 centimeters in the splenic artery, aneurysm-wise, that's a grounds for having a vascular surgeon go in to do some kind of an intervention to prevent that complication. Mesenteric ischemia is always a concern, and there are criteria, again, based on peak systolic velocities and end-systolic velocities in terms of evaluating stenoses. And of course, there are syndromes related to the anatomy itself. You can have what's called celiac artery compression syndrome or median arcuate ligament syndrome. And this is where the median arcuate ligament of the diaphragm can actually cause dynamic compression of the celiac artery with a respiration. So when the patient inspires, that can actually cause the celiac artery, the diaphragm to flatten out and the celiac artery to get pinched by the cruce of the diaphragm in the process. Oh, and this is out of order, but this is essentially showing this is showing on rotation here a splenic artery aneurysm. If you just watch it, you'll see a spherical appearance. Let's see if I can bring the laser pointer. There's a spherical structure right here that indicates a splenic artery aneurysm. In terms of renal artery stenosis is always a concern, but of course the renal arteries can also have additional feeders, and one should be able to recognize accessory arteries and of course aberrant arteries. The difference between an accessory artery versus an aberrant artery is that an accessory artery will head for the renal pelvis, to the renal hilum, whereas an accessory artery will head to a completely different direction. And shown on the left are a bunch of accessory renal arteries going to the right. Shown here is an aberrant artery heading for the inferior pole of the kidney. There's something called the resistive index, which is simply the end diastolic velocity, which is 1 minus end diastolic velocity over peak systolic velocity, and that's one of the criteria for looking at renal artery stenosis. There's also the renal artery ratio as well, and this is criteria from the University of Washington. There are some newer techniques that some researchers are looking into, and this is using MRI. This is a technique called arterial spin labeling, where they can actually tag the arterial blood as it's flowing into the kidney and get an idea of renal perfusion this way as well. So a different way of looking for renal artery disease. Moving down a little lower to the pelvis, and then finally the portal system. There's an entity known as pelvic congestion syndrome. So as you all know, there's a left gonadal vein that goes up to the left renal vein, and so this can be obstructed and cause congestion. And some patients, especially female patients, may complain of vague symptoms. So this is something that can be evaluated for. I mentioned the pre-aortic course of the left renal vein, and this can be manifested as a one complication known as nutcracker syndrome or compression artery syndrome. And so there are various entities various criteria that one needs to look for. There's pinching of course by the SMA and the infrarenal aorta. There's going to be post-stenotic dilatation. Usually a very sharp angle less than 60 degrees will also predispose the patient to developing the syndrome as well. There's a correlator to that down in the iliac branches, where because the right iliac artery crosses over the left iliac vein, the right iliac artery can actually pinch the left iliac vein against the spine and lead to what's called May-Thurner syndrome, or iliac vein compression syndrome. And so these patients will manifest, again, with pre-stenotic dilatation, left lower extremity edema, and even DVTs in the more extreme cases. So this is something that we can that can certainly be evaluated in the vascular lab, but we do it all the time in MRI. We can actually do dynamic imaging and demonstrate dynamic compression as well. And last but not least, there is portal hypertension. So liver cirrhotics are the most obvious patient population that are affected by this. We can look at flow patterns on the portal vein. Normally, the portal vein has what's called hepatopedal flow, whereas hepatic arteries have hepatofugal flow. The arteries, when they feed the liver, will flow away towards the liver, whereas the hepatic veins will go in reverse. And I'm sorry, the portal veins will actually flow alongside the artery as well. And this actually comes up on vascular ultrasound boards on occasion. With that, I'd like to conclude. After that whirlwind tour, the imaging assessment of vascular disorders requires knowledge of all the various entities, and I did take you on a whirlwind tour, I admit, but knowing the anatomy, knowing the dynamics of what's going on will help immensely in terms of interpreting what's going on in terms of that vascular bed. The vascular laboratory does remain the first-line modality for assessing many of these entities, but CTA MRI does offer a good non-invasive option before the patient hits the fluoro suite. With that, does anyone have any questions?
What's the status of IMT now?
What's this?
Do we measure it? Do we report it? Knowing all the issues of measurement.
So,
you may want to repeat that question.
Absolutely. So what's the status of IMT now? Do we measure it? Do we report it at all? In the routine carotid ultrasound setting, it hasn't entered clinical use. Unfortunately, it did lose out in the 2013 cardiovascular risk prevention guidelines, prediction guidelines. What they said at that time was that it still needed a lot of data. And they are kind of correct, because carotid IMT by itself is less predictive when not combined with plaque. So the issue with a lot of the research studies done in the past is that they reported IMT plus plaque disease. Plaque disease is far more predictive, and that's usually better noted. So when that's present, that's suggestive of the patient being at higher risk. But in terms of routine clinical reporting for carotid ultrasonography, no, it's not used. Any other questions?
How does CMR compare with Doppler when you look at patients with portal hypertension? Is it Doppler that we should order in these cases, or CMR or MRI?
I'll just say that the last time we had a portal hypertension case referred to the CMR lab, I asked Dr. Shah, I didn't know we assessed portal hypertension. His response was, I didn't know we did either.
Okay.
So, but yes, in the literature, it's reported.
Now, the nutcracker syndrome, my understanding is the implication is not the compression of the left renal vein itself, but what drains into the left renal vein. Is that correct? Meaning, for example, the left testicular vein drains into the left renal vein, and that is one explanation why it's more common to get a left hydrocele as opposed to a right hydrocele.
Correct. So the question was, or the statement was, it's not so much the compression of the left renal vein that's important, but what drains into it. And yes, Dr. Naga, you are correct. The left gonadal vein, as I mentioned earlier, does drain into it, and so that can manifest as hydroceles in men or pelvic congestion syndrome in women.
Is the May-Thurner syndrome more common in women than men? And does that enter in the differential when you see lower extremity edema in pregnant women?
Is May-Thurner more common in women than men, and is explanation when pregnant patients present with lower extremity edema? in our center's experience, we tend to see more women with May-Thurners, and it tends to be, although it tends to be more to be smaller body habitus that we see the entity more in. We have seen men with it as well, but yes, there tends to be a preponderance of women. In terms of the anatomy for women, for pregnant women, that may have to do more with the gravid uterus compressing on the IVC more so than May-Thurners by itself. And that's why pregnant patients are often advised with edema to try laying on their side as well. Any other questions?
The CMR show all the vessels beyond the popliteal artery well in the lower extremities, anterior tibial, posterior tibial, that sort of thing, that would replace invasive angiography?
Does CTA MRI show all the lower extremity runoffs like the popliteal, anterior tibial arteries, et cetera, well compared with invasive angiography? It's actually comparable. I showed sensitivity and specificities for picking up PID disease on the order of 95–96%. I do admit we tend to overcall, and that has to do with the spatial resolution of CT and MRI. But yes, it does tend to pick up a disease quite well based on literature.